Hello, and thank you again for inviting me to be a part of this year's Egyptian Hypertension Society meeting. It's always a pleasure to be with my colleagues in Egypt and my many, many good friends. Today, I'm going to talk about treatment and control of high blood pressure and the way forward. Many of you know me well, but for those of you who don't, I am Paul Whelton. I'm in the very southern part of the United States in the Gulf of Mexico at Tulane University in New Orleans. And I'm also president of the World Hypertension League. I have no conflicts of interest. So when we look at high blood pressure, it is the most important preventable risk factor that has ever been identified. And Global Burden of Disease Group has studied many risk factors. Here we're looking at 84 different behavioral, environmental, occupational, and metabolic risks. And blood pressure is the most important one. It's the only one that causes more death and more disability-adjusted life years of burden than smoking, high glucose, overweight, and many other factors. These are all important factors, but clearly the most important is high blood pressure. Now, we know the approach to prevention of high blood pressure and the approach to management of high blood pressure. For both of these, we can use non-drug approaches, and there are many of them, but there are 6 that are really very well proven to be beneficial. Weight loss, healthy diet, reducing dietary sodium, increasing dietary potassium, physical activity, and moderation or abstinence from alcohol. In addition, we know a lot about drugs. We've effective drugs since the 1960s, and we have many comparisons that tell us drugs are way better than placebo. Not much difference between different classes of drugs, except the diuretics are much better for prevention of heart failure. We have looked at different intensities of treatment. We know lower is better than higher. And we're now in the phase of many trials that are looking at strategies for how we implement what we know. And of course, we have many meta-analysis. Now, based on all of that, this is what we recommended in our US guidelines and for the American College of Cardiology and American Heart Association. For the pressures when they're down in the less high area, we say stick with non-drug approaches and make them more structured as that pressure begins to creep up. When you get into the high pressures, 140 systolic and above, then we clearly see the need for both non-drug approaches and drug approaches. And it's in that middle area, 130, 139 systolic, that it's important to know whether the person has other risk factors. What is their underlying cardiovascular risk? Have they had an event, in which case, obviously, they're at high risk for cardiovascular disease? Or if not, when we do risk estimation, do they appear to be high? It's a minority of that group, at least in the US, but for those who not only are in that blood pressure range, but have high underlying cardiovascular risk, we would recommend the combination of non-drug approaches and a drug approach. For the others, we'd say, try to stick, if you can, with non-pharmacological approaches. Now, how are we doing? Well, since we know that reducing blood pressure is very effective, in fact, it's one of the most cost-effective strategies that we've ever identified, you would think we would be doing great. But indeed, when we've looked at the data, even for a target that is less than what any guideline, the major guidelines at least, would recommend as optimal, that is 140 or above, we have seen, our group has done global estimates, and they've improved slightly from 2000 data to 2010 data. We're now updating that again. But it's still bad worldwide. Only less than 14% have control to less than 140 systolic. When we look at countries like Egypt that are in the low to middle income category, the situation is even worse, less than 8%. That's abysmal. That's shocking. That, you look at that and you say, something is terribly wrong with the system, because Here we have what everyone agrees is a very effective and cost-effective treatment, and it's not being applied, and not being applied very well. So we've got to have a different way of moving forward. We're looking at that now. There are a lot of implementation trials going on, and the pattern that seems to work well, and it's a pattern we've recommended to the World Health Organization in their HEARTS program, which the World Hypertension League is very actively supporting, includes a background of health promotion, that's a given, making access to care easy, community-based, patient-centered, team care. We know team care is very effective, making sure that blood pressures are measured accurately, a reliable source of effective and affordable medication, preferably at the point of treatment, and use of simple evidence-based protocols. We don't need anything fancy here. Simple protocols for lifestyle improvement. Any hypertensive drug treatment doesn't have to be administered by the physician, can be under the supervision of a physician, but many other people can administer this very, very well for routine hypertension. And tracking systems, who is coming for treatment, who is being treated, who's effectively controlled and who's not, and then immediate case management, going after the people early who are not well controlled. That's basically the approach that works well, and that's the core of the HEARTS program. Now, I just show you one of the more recent team-based care studies with this type of model. This is from China, from very rural China, with community healthcare workers. We used to call them barefoot doctors in the past. They have about 2 years of rudimentary education for healthcare. And this is a cluster design trial, a big one, with many clusters. The clusters are the villages. And you can see what happened over time. For the villages that applied the type of model I showed you in the previous slide, compared to usual care, they did much better. Over time, huge differences in blood pressure. By 30 to 36 months, the systolic blood pressure was over 20 millimeters lower in the intervention villages. So that's telling you that this rather simple approach, when it is well executed, well implemented, gives you huge reductions in blood pressure. And as you'll see in the table, you would get the expected enormous benefits in cardiovascular disease outcome and reduction in all-cause mortality. When you apply this in systems of care, it also works, and it doesn't seem to matter whether you're in a high-income country or a middle or a low-income country. This is from the United States, from one of the systems of care, Kaiser Permanente. They used a model very similar to what I showed you, easy access for their patients to get blood pressure measured accurately by technicians, simple treatment protocols, close follow-up and tracking. And they improved their care dramatically over time. So I think we know the way forward, and it's based on an evidence-based strategy for prevention and control of high blood pressure. Most patients have uncomplicated hypertension. They can be managed with very simple algorithms. They require little physician oversight or time. Patient engagement, patient-centered care is very important. Access to effective and affordable medications, preferably at the point of care, is very important. And tracking and case management with immediate corrective action is very important. With that approach, I think we'll do well. The current model of care that we have in most countries, which is the physician-centered care, is not working. It's got to be replaced. So in summary, high blood pressure is the most important of the cardiovascular risk factors. Our current model of care is failing abysmally. And unfortunately, we have tacit approval by providers, systems of care, and payers. And of course, our patients are the one who is suffering from this. The way forward is implementation of a new care model emphasizing specific commitment to high-quality, results-oriented care, health promotion, convenient patient-centered team-based care, simple protocols for lifestyle counseling and antihypertensive medications, easy and dependable access to effective and affordable blood pressure medication, and tracking and of progress and case management. That's what we're doing in Hearts, and it's making a difference. And so I hope some of these elements will be helpful to you as you consider your model of care. Thank you again for inviting me to be with you today. It's always a pleasure to be with my very dear friends and many colleagues in Egypt.
Thank you very much, Paul. It is good to see you and listen to you. In Egypt, we have a complex problem. We have the problem of overdiagnosis of hypertension and the problem of undertreatment of hypertension. Many individuals are diagnosed as being hypertensive who are not hypertensive, just simply on a casual office reading, and by repeated measurements, they turn out not to be hypertensive. On the other hand, many people who are hypertensive, either because they have no symptoms or because of the cost of medications, they discontinue treatment. So, and I don't know about the situation in other countries, but here we have this double problem of overdiagnosis and undertreatment. We don't know what to do about it. Maybe public education or physician education, whatever. What do you think?
Well, first off, lovely to see you, Mohsen, and other colleagues in Egypt as well. I completely concur with you. One of the unfortunate, we say in the US, dirty secrets is that we do a terrible job in blood pressure measurement. And one can go back to the very early days of blood pressure measurement in the US. Janeway said in the early 1900s that standardization of the measurement was very important, and we can fast forward. We know that's important. We know that the evidence is derived from cohort studies. To a large extent, the risk evidence comes from cohort studies and from randomized controlled clinical trials, where there was training and certification of the blood pressure observers. So the blood pressure measurements are done fairly well in those studies. And if we want to practice evidence-based medicine, which most physicians and clinicians say they want to do, you need to use the same approaches to blood pressure measurement as in those trials. We know that that doesn't happen, and Egypt is not unique. We have documented this in many countries. In our country here in the US, the only training that most physicians get is one of their very first courses in medical school. And it is impossible to get our accrediting bodies and to get our payers and their surrogates to take the issue of quality of blood pressure measurement seriously. We know in trials, for example, in the SPRINT trial, we trained, certified our observers. And when we compare the blood pressure measurements in the trial to the blood pressure measurements on the same people taken in the clinical setting, and they're recorded on the electronic health record, those latter measurements on average are higher. But when we compare them, it's very much like you said. There's a big spread of the data. On average, people are higher, but there are certainly people who are falsely getting low readings in the clinical setting. And that difference varies over time. It varies by practice setting. It varies by level of blood pressure. There's no way to correct for inaccurate measurement of blood pressure and come up with what we think is the correct measure. So it's a huge issue. There has been over time many efforts to try to deal with it. There is currently an effort that is being led by KDIGO. There are 15 to 20 professional societies around the world working together to try to fix this problem. I think in the long term, we may be able to deal with this when we get clinically valid cuffless blood pressure measurements. Currently, not a single one of the cuffless measurement devices are clinically accurate, so they're no good. But I have some confidence that over time, we will sort that out. There's a huge amount of money being invested by many, many different companies who are involved in technology to try to address this problem. So that could be a solution and could certainly also open up in a relatively easy way access to nighttime blood pressures, which of course it's very hard to get right now. But I agree with you. One of our big problems in blood pressure measurement is inaccurate blood pressure measurements. We know how to do it, and it's just like treatment. We just, many times, people either don't have the knowledge or they have the knowledge, but they say it's too difficult. We don't have the time, we don't have the money, etc. So in many systems of care that do a good job in blood pressure measurement for routine, uncomplicated patients with high blood pressure, they have trained technicians who are on a much lower salary than physicians or nurses or pharmacists, trained technicians who can measure blood pressures rather well, and easy access for the patients to get their blood pressure measurement. That's, I think, probably at the moment, the best way forward. And physicians probably ought to be using their time judiciously for more complex and complicated care of hypertensives. So that's a long answer to your question, which is an excellent one. It's a huge problem.
Thank you, Paul. Dr. Rafael Arusi, I wonder
Hello,
if you still
Professor
remember.
Whelton.
Well,
It's always a pleasure.
lovely to see you.
Me too. I'm so glad that in your presentation, you have paved the way, as always, for the systematized protocol for prevention. And I'm honored to tell you that, Professor, with the guidance of Professor Ibrahim, we have started our prevention control program among the most important activities of the society. I have been following the algorithm that you have placed in your slides in the last 2 or 3 slides, and I've seen that you depend upon paramedics or others to measure the blood pressure. I know this is not applicable in Egypt, but I'm glad to tell you that we have started this by teams, well-trained, as you taught us in the prevention, in the National Hypertension Project, and we are trying to implement the use of automated devices and home blood pressure monitoring for patients. So would you recommend, as you mentioned, the low salary for measurements personnel, or just keep on doing this with the available personnel that we do have among the pharmacists, which is one of the arms for the prevention program? The second point is, do you have a nutritionist advising those people for the lifestyle, or you just have a brochure or printed material to distribute? Thank you.
Thank you, Wafa. I would say in terms of the former, when we look at the systems of care now, the model of care in most countries, you know, we look at it and it's just not working. The traditional model, the patient comes in, sees the physician, has the blood pressure measured badly, the cuff is slapped on, their feet are dangling off an examination table. That's not working. It's not working for a diagnosis, and it's not working for management. So I think we have to step back and say, this is awful. And it's not an Egyptian problem, it's a problem worldwide. It's a problem in the US. We may be doing a little bit better than you, but we're not doing well. So we have a problem, and I think we have to look at it and say, the systems of care that we are using for chronic disease, and it's not just blood pressure, it also applies to diabetes and other areas, but it's certainly in blood pressure, they're not working well. And I think we have to acknowledge that, and acknowledge that we have here one of the most cost-effective treatments, and there's something wrong with the picture when we know these treatments work very, very well, but they're not being diagnosed properly and they're not being treated properly. So I do think doing what you're talking about, trying to change the system of care to provide a better model for our patients is appropriate where it can be done. And in the World Hypertension, in the World Health Organization, WHO guidelines, I believe that those are the only guidelines where we have put in a recommendation for consideration of non-physician management of high blood pressure. And we've put in, and this was done by colleagues from all over the world, what we thought would be the requirements for individuals participating in care of hypertensives who are not physicians. And there are legal requirements, obviously, in most countries, and there are practical requirements. So I think that can be helpful. In terms of non-pharmacologic interventions, again, we know the things that work, and we know how well they work, and they work rather well when they're well applied, but they are difficult to apply. It's difficult to change lifestyle. At the moment, most of what we do is trying to change lifestyle, and the only opportunity, that's a big one, is sodium, where in most countries, particularly as the economies improve, we tend to move towards using processed foods. And when foods are processed at the moment, companies add a lot of sodium. So in the high income countries, about 80 or 90% of the sodium is coming from food processing. It's not quite the case in some countries, but it's moving in that direction in all countries. Now, I would say there are different people who have skill sets for advising on lifestyle management. Some physicians do it, but we usually don't have sufficient time. There are some nurses who are good at it. There are some dietitians who are good at it. There are some dietitians who are not good at it. There are therapeutic dietitians. They can write a diet, but they don't know how to change behavior. There are many community healthcare workers who are trained in the delivery of behavior change. So I think it's a matter of looking to see who in the team or who in the community is good at this and has a passion for it and can do it well, and taking advantage of that person. There's a background, obviously, of advertising and encouraging it as well. When we've done our more recent implementation trials, we've used very simple protocols and trained whoever was the key person. In China, was the community healthcare worker. We've trained them in how to deliver lifestyle change advice, and we've trained them in the use of very simple protocols for how to manage medications. And I was listening to Neil Poulter, and I think a lot of what he said is very important and interesting, but applies really to the more complex care patient, the patient who's having trouble. That's where the physician needs to come in and really play a very active role. For a lot of our routine care, maybe 80% of the management of high blood pressure, it doesn't need to be complicated. Complicating the situation actually is counterproductive. I often say that management of blood pressure, for the most part, is one area where personalized medicine and precision medicine is counterproductive. And I would say the simple public health approach of using algorithms that just say A, B, C, D, E are the ones that seem to work very, very well in most countries.
Thank you very much, Professor Whelton, and we are always pleased to have you among us. Maybe next time you will be present in person. I hereby, due to the time limit, thank you again on behalf of the organizing committee, and have a nice weekend. Thank you.
Nice to be with you.